So do we have everybody on here that was expected to be on here? Yvonne, Chris, myself, Rainer?
Yes, sir.
And we got a few more trickling in from the waiting room. It looks like everybody's cleared the waiting room. I did not see Mike log in. So he's the only board member I did not see on today.
Mike will not be here.
Okay.
I will be chairing it today.
Okay. Well, it looks like we cleared the waiting room. So if you want to go ahead and start, I'll turn it over to you, Barry.
Okay, then. Thank you all. Appreciate it. Welcome, everybody. Want to establish that we have a quorum.
I'll take roll. Mike
Chase.
Cottle. Yvonne Egan.
I was muted. Present.
Chris Kaiser.
Present.
Barry Martin.
Present.
Rainer Mullins.
Present.
You have a quorum, Chair.
Okay, sounds great. Appreciate you guys taking the time to be here. Everybody have a chance to review the minutes of our last meeting?
Barry, do we call them minutes or do we call them transcripts? How do we need to make a to define them differently now?
I think we've been working on that. I'm not really sure. Veronica, are you on here?
Yes. Hi, good morning. This is Veronica Judy Cecil with Medicaid. So the transcript serves as the minutes. I don't think we need to distinguish them. It's just that's what is being utilized as the minutes at this time. And we can talk a little bit more about it. I know it's on the agenda.
Yeah, I know. We'll talk about that. So let's go on to old business. Follow up on personal meetings. I know we talked about trying to have one at least annually.
Hey, Barry, if I can interrupt you for a minute, I don't think you actually approved did a vote to approve the minutes.
Oh, I apologize. I did.
I interjected. Barry, this is Chris. I'll make that motion to approve the transcript and minutes. And
okay, we have a
second that.
We have a second. All in favor, Rainer, say aye.
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 Aye. So moved. Thanks, Veronica, for the clarification. Keep me on Robert's rules. Old business, follow up on personal meetings, person-to-person meetings.
Veronica, did you want to handle that or did you want me to?
I'll let you take that one.
Okay. So far, we have been having the TACs kind of vote and decide what they wanted to do. Most TACs so far have decided that they like the Zoom as long as they can because they have better participation. And for people who don't have to travel, it makes it easier for them. But we have been kind of leaving that up to some of the TACs, as they see fit. Some of them have opted to maybe do once every few months or once a year in person. So I've just been trying to request that they let me know in advance. Part of the issue is public health had some flooding and the rooms are being renovated. The LRC building is not allowing us to use their audio and video equipment. And so it's been a little more challenging trying to find a location, but we have been working through some of those issues if a TAC decides they would like to meet in person. The MAC had originally wanted to meet in September in person, but then decided to stay virtual just due to the rise of everything and people not necessarily being comfortable being in a large group. So we've kind of left that up to each TAC to kind of discuss what they would like to do.
I personally think we should probably get through winter, maybe the first part of spring, maybe try in the latter part of spring when the weather and hopefully other conditions clear up. So why don't we just say that we will continue on virtual and we'll reconsider it in the spring.
Okay. And I am working on 2023's calendar currently so that I can go ahead and get those dates out to you guys, you know, to look at and approve moving forward through the next year. So maybe once that calendar comes out, you can look at some of the spring dates and let me know which one you guys think would work best. So I hope to have that out within the next week or two to all the TACs so that they can start looking at their calendar for the next year moving forward.
Okay, that sounds good.
I think to stay virtual and then revisit in the spring. I think that's a good idea.
I support that too.
I concur.
Okay, sounds great. We'll put that on the to-do list for next year. Follow up on the dental workforce recommendations, Rainer?
Yes, just wanted to get an update from Monica on that. I think those recommendations are even more important given the recent developments in Eastern Kentucky and also the announcement of the third dental college for Kentucky by UPAC. So Veronica, just wanted to see where things stand now.
Absolutely, thank you. And we shared that with the Secretary, Secretary Freelander. What we'd like the next steps to be, if the TAC is okay with it, Dr. Julie McKee, who's the dental director over at Department of Public Health, has done a survey and has information related to workforce. So we thought maybe at the next meeting we could invite her to come and present. And then we have also pulled together some information about coverage of dental services, including oral surgery, to show kind of what the current state of Medicaid is. And then, you know, and so we can present that information and talk with you all about what you all want to see as the next step. The commissioner presented that information at the Kentucky Dental Association conference on Saturday. And I know what we're interested in is making sure that it's a collaborative effort. So I think the association has to be involved, the schools have to be involved, because it's not something that Medicaid can solve. We don't have control over you know, how many dentists come out and whether they stay, because a lot of the, I think, tools available to attract and retain the workforce are out of our control. So we think it's important to have everybody at the table that could play a role in developing, you know, whatever programs or policies that, you know, will help us recruit and retain dentists in the state and in Medicaid. So that we wanted to offer that up if that seemed like a good next step for you.
Oh, well, it certainly sounds reasonable to me, Veronica, and you know me for a long time. I'm totally supportive of getting everybody at the table. I think a very important first step, though, is to get an accurate baseline of where we are and how we got there, that everybody has access to transparently and knows exactly kind of where we stand. And so it makes sense to me, the next steps. You know, there have been problems in getting an accurate documentation because of the data. So I'm hopeful that you've made some progress on that. And I look forward to hearing the updates.
Okay, well, again, if it's the pleasure of the TAC, you know, we'd be happy if you want to put that as an agenda item.
Yeah. I recommend that we support Veronica's, we accept Veronica's offer and hear a report from Julie McKee and Medicaid on the latest available information.
Yeah, this is Chris. I think that's a great idea. We can, you know, have it on the next agenda if that works for them.
This is Giovanna. I support that also.
Okay, so is that just going to be a continuing agenda item for TAC and nothing for the MAC?
That's what I recommend, is that, you know, we continue to talk within the TAC. Yeah.
Okay. Sounds good. We'll just continue to keep that on the agenda. Next, update on the request of the last meeting. The MCOs could develop a crosswalk benefits for the SUD patients in recovery. I know I've seen some emails coming out from the different MCOs in regards to that. I think that ought to be just like everything else the MCOs provide, is more information for the providers to help our patients, MCO and providers' patients. They're all our patients. So I think MCOs ought to continue to do that for SUD, for behavioral health, for chronic disease management, for anything and everything that we work collaboratively with. Has Chris and Yvonne, Rainer, have you seen enough information coming through about crossovers?
I saw the information coming through from WellCare. I haven't seen if the others had sent out, I had missed it, but I think the information I saw is very helpful. And I do think that this information is so important for us to be able to make sure we're offering the best that we can for our patients and getting these services out there. The question I have is, to Medicaid, is this something that you're going to recommend that they do, or is this something the MCOs just take on their own?
I really think that this came about as a topic of discussion. Once again, I think this is no different than anything else that we've been working on. I think they just need to be focused on giving more information as providers of the services that they provide.
Sure, but I'm sorry, Barry, but a true crosswalk though just is, helps us that all the information is in one place, and you can see, this MCO does this one does this, and instead of providers searching, for a piece of paper that this is WellCare's plan, this is Aetna's, Humana's, etc., that we kind of see them side by side. Yvonne, do you think that kind of format is more helpful than just getting separate emails with information?
Very much, Chris. I think it's just too difficult when you're out there and you're dealing with 6 MCOs that have to keep going and searching each of their sites. If it could come together in one document, as you suggested, I think that would be the ideal solution.
Yeah, I mean, I just envision providers, in a room with a patient and trying to have a discussion, and they, what insurance are you covered under? Okay, let me look in my file, and I've got to find this loose sheet of paper that has that particular insurance's information. So a true crosswalk, I think, is the providers would find more beneficial.
Can you all help us understand 2 things? One is, what do you mean by crosswalk? Because crosswalk usually means you're taking one thing and comparing it to something else. And are you talking about value added benefits for people in recovery? Or are you talking about the actual services that we cover?
I think it's the actual services, Yvonne, right? Yeah. Mm-hmm. So
okay, we can, because all the MCOs are required to cover all the Medicaid services. So if it's just understanding what those services are, I think that we can help prepare that, because every MCO should be providing the same coverage. Now there may be some, and the reason why I wanted the clarification is because some of them may be offering housing supports or, some other job supports that aren't Medicaid coverable. And so I wasn't sure if that's what you all were trying to focus in, or if it's just trying to refer somebody or to help a Medicaid member understand what is covered under the SUD benefit.
I think it's a combination of both. I mean, it's definitely wanting to help the patient understand what benefits that they are eligible for, but also are there ancillary things that may not be covered, but yet the MCOs can help facilitate in some form or fashion, like you were indicating.
Okay.
Yes, I agree.
I mean, does the MCOs do that for any other service, like behavioral health in general, dental in general? I guess I'm just trying to figure out if we're going to do it for SUD, we probably ought to do that for everything else. I mean,
so I think here's the struggle, right? The benefits that we cover are in our regulation, and so but I can understand as not a typical SUD provider, you don't understand what's offered. So we can kind of put that. In fact, I think we have a slide that talks about all of our SUD services. The value added, I mean, we can provide you the value added visual. It has each MCO and all the value added benefits that they provide to their members. We could, so right now I'm asking MCOs to email us if they have additional things that might not be on that value added that are specific to SUD patients in recovery. Because like I said, I mean, I think that sometimes their case management might be able to offer them, housing and food and some other benefits that aren't specifically on that grid of value added. So we can do that. But I'm not sure, Barry, how, what exactly you're looking for all benefits covered by Medicaid. That might be a little.
I guess my question is, if we're doing it for SUD, what's going to stop us from asking it for dentistry, for other services? And I mean, that would be great, but that's going to be a huge list with a lot of ever changing, because we know that the MCOs and DMS is always changing things and services and adding and kind of diminishing some. So,
Barry, I mean, I think it's a good place to start, particularly because more clinics are going into social determinants of health, and looking for barriers to care and access and things like that. And, when staff identify a particular need, then again, if value added benefit that comes from the MCO, having it all kind of in one document, they can say, oh, I remember, this, and look, and here's a resource that you can, is tailored for you because of, you having this particular MCO. So I think it's a good place to start. Yeah.
Okay, that's helpful. Thank you.
I'm all for it. I just know that we can inundate DMS and MCOs for other requests like this, and I guess just want to be cautious. It'd be a great tool. We're diving into SUD hard and heavy, and it would be a great tool to be able to look at it. But to be honest, you don't really know what they're going to cover and what they're going to say until you call and get your PA. That's the proof in the pudding, because you could be told yes or no for those services. But it would be good to have something consistent to use as a table of services, and know which MCOs offers different services. So, and I guess instead of it being called a crosswalk, why can't it be called a summary of services?
Yeah, I mean, I think it's semantics as far as, you know, if they identify a crosswalk as being a little bit different, you know, again, a summary of services, sure, from each MCO on, you know, on one document, one piece of paper, or as just having it all together, comprehensive would be great.
Okay. Any other discussion about that?
It's Paulette with WellCare, and I think, you know, I do know people change throughout the organizations, but I think also having some key stakeholders on who can help navigate the substance use disorder benefits for you would be helpful. So maybe we can add some people to our grid that would be go-to people to help determine what's best with you for the members.
I think that would be very helpful. Veronica, I mean, you all did the summary of, with the COVID and what people were offering, and when that was distributed out to clinics, I mean, they found that very helpful. But I think this tool would be very helpful as clinics are expanding their you know, substance treatment program.
Okay, so we'll keep this on the agenda. Updates on the end of the PHE and the wind down process. Veronica?
Yes, sir. Well, we did not receive the 60-day notice from CMS by August 14th, which means that currently the public health emergency was scheduled to end in October. That will then be extended another 90 days. So we're looking more around January 14th. We have, you know, we continue to work on it though. We, you know, primarily we're focusing on our systems and making sure that everything that we did to change our system for the public health emergency, we're going back and verifying that we're unwinding that. We have engaged a new consultant, Alterum, who is going to help us now with sort of the next steps that we wanted to do, which is engage stakeholders, and that includes providers. So you probably will be hearing more. We'll be sending out things to the MAC and TACs as we move forward with that effort. We're going to engage advocacy organizations, the MCOs, and just be more transparent about our plans and what's going on and who's affected and how many. So you'll be hearing more from us on this to keep periodic updates.
Okay, appreciate that. Any questions about that?
Yeah. Thank you.
Update on the provider signature regulation. Update to align Medicare and Medicaid to the same time frame.
Good morning. I'm Jonathan Scott. I'm Regulatory and Legislative Advisor for DMS. That change is in 907KR 1082, and it is going through our regulation promulgation process. Right now, we're working on a statement of consideration that should be filed by September 15th. And then it would be on ours in October, and hopefully on health and welfare in November, and the rate will be effective after that. In the meantime, there is a additional option that has been pursued to allow for a longer time in which notes can be fixed, and that is to rely on Section 2 of 907KR 3010, because the concept of a provider in that regulation would also apply to the RHC providers. And I think that's all. Sorry.
Ours is the Administrative Regulation Review Committee, subcommittee. And so, you know, we did file the regulation. as Jonathan mentioned, it's going through the normal process. And until then, as we indicated, the department is not enforcing the current shorter time. We've aligned with all the other requirements.
So we'll keep that on the agenda until it's finalized. Last item on the old business, request to have meeting minutes. I know after we've changed transcribers, we used to get kind of a summation of the transcription. I guess you guys really don't have anyone that can do that. I don't know if Chase, is there any way that maybe we could put together something to have for a summation of minutes that we could submit to DMS? And is that an option, Veronica, for somebody to kind of summarize?
Yeah, you know, again, a couple of the TACs have done that on their own. And first of all, let me say, you know, we have a list of court reporters that we use, and they just don't offer that service. And you all don't have to submit minutes. If you all want to create minutes, you all can create minutes and then vote. We don't have to approve those or anything. That's just something you all would vote on. We don't have the capability. The commissioner, you know, said that if, you know, there's serious interest in this, we could potentially hire somebody, but that process takes 4 months. So, you know, in the meantime, if you all want something other than the transcript, you know, you all could potentially find somebody that could do that in-house.
Okay. I think that's something that we may entertain. I just
Barry.
Yes.
Barry, if I may. Oh.
Okay.
Yeah, I think
Chase.
Yeah, so I think Chase can fill in more, but we have been taking notes to circulate. They were, and we'd be happy to continue doing that for members, and I can identify who wants that. But I think that that's an important part, is for us to transcribe or to help facilitate the dissemination of the information, and be respectful of everybody's time, because I know transcripts are hard to read through.
Okay.
Barry, if I may, I'm happy to make a summarized minutes. I do want to clarify though that the minutes that DMS has been providing, the transcription, doesn't come until fairly late. So I think it would be best if we do minutes, that those aren't something that we vote on, that we leave the transcription as their official minutes, because they're going to have all the information where I'm working off of just notes I'm taking along as I go along with the meeting. If that's,
I tell you what, Chase, why don't we let you do that a couple times? Let's look at it. The thing that I don't feel real comfortable about approving the transcripts is you're approving a lengthy thing that nobody's really going through looking at for action. And something could have been said that's inaccurate. We're approving it, and somewhere down the road could that kind of nip us. So
yes, sir.
I'd rather get to a point where we feel comfortable with a summation of the transcripts, and then we submit them to the TAC members and to DMS, and have the TAC members to approve that.
Yes, sir.
I will say, and Aaron, correct me if I'm wrong, we have worked out with the court reporters that the transcript arrives no later than 30 days following the meeting. And I think a lot of them are getting to us sooner than that. And we distribute them as soon as we have them. So Aaron, what's been your experience?
Yes, ma'am, that is correct. When we first transitioned, we had one court reporter that did the majority of them. And when she had to step down for personal reasons, that first 6 weeks to 2 months, we really kind of, excuse me, bombarded our other court reporters. And so I have reached out to them and let them know that we do need those within 30 days of the meeting. And so far that has started to, they have been getting them back to me faster. The moment that they hit my email box, I turn around, I check them to make sure everything seems to be there, and I email them to you before I even save them to my own information. So I do try to get those out to you just as soon as I have them. And they have been working on getting those to me faster.
So, Veronica, you had made a comment that the commissioner had said that they could hire someone, but that would take 4 months. Is that something we need to request to be done, or is that something that's going to be done?
I think we wanted to see what the pushback is for finding alternative ways. Like I said, you know, we have a couple of TACs who have just been doing this themselves anyway, and they utilize an association, or the chair does the summary. It's not. I will say that it's not really where we want to go, is to have to hire somebody to do this, but we're here to serve the MAC and TACs, and if that's what's needed, we'll move forward with that. I think we wanted to kind of get a dialogue with those entities that are, those MAC and TACs that are really interested in having us do it, to kind of see what alternative arrangements could be made before we take that action. Because we'd have to establish a position and then post it and then interview for it. And so it does take some time.
And if we create our own, I mean, Chase, there's no, I guess, no responsibility or obligation on your part or KPCA's part. It's just something that's going to be proposed to us, and we can choose to accept it or modify it or whatever. It's just, I think it would be beneficial if we had some kind of summation for us to look at, other than just say the transcript was submitted, we approve it and move on.
Well, Barry, this is Chris. I mean, I think a summation would be helpful, particularly just whether it's, you know, bullet points of if a motion, you know, if an action took place, that we capture, you know, how the motion proceeded. And then like the continuation of the business items, a notation that says this will be continued next time, or it's been resolved, or, you know, something along that line, because we don't need all of this dialogue to be pulled into the minutes per se, or a summation per se.
Right. So if Molly and Chase, if you don't mind.
I can definitely get those to you.
Okay. Appreciate it.
Of course.
Right. Thank you.
Okay. Going on to new business. Something that I've kind of been talking to some of the other providers, talking to KPCA and talking to Veronica, is, you know, the need to try to standardize measures across the MCOs for rural health clinics and FQs. It would be nice if we have a summary of services or quality indicators from all the MCOs. And it would be even better, you know, with Medicaid establishing a core group that we all agree on of quality indicators. And then I know the MCOs may have the option to add to that, but at least get some consistency across the board as much as we possibly can. Is that something, Veronica, that we could strive for?
So we, as you all know, just did a reorganization, and we created a division of quality and population health. And as part of that initiative is really to work on, for instance, we're working on our quality strategy required by CMS, and kind of try to more align the work that we're doing to drive outcomes. So I think we're absolutely open to, you know, what kind of value-based contracting programs do we want to see, and because working together, I think we would better drive those outcomes. So yeah, I mean, we're definitely open to it. I don't know if Angie Parker is on. She's the director of the division, and I'm not sure if I see her. So she's apparently not on. So anyway, we shared that with Angie when we saw this on the agenda, and certainly something that we can continue to talk about as we move forward with fully implementing that new division and our efforts around that.
Okay, I think what we're looking for from the Primary Care Association, providers, and TAC is for us to be able to, you know, it all stems from DMS, working with the MCOs and then with us. If we can work with DMS and agree on some common ground, then they can help with DMS and contracting, because ultimately you guys contract with the MCOs, then we contract with the MCOs. They get direction from you guys and work from that. So if we can work directly with DMS and develop some of these standards, then we know that the MCOs will follow suit. And we know that there'll be some outliers, but we would like to limit those outliers because we really would like to get focused on a core group of qualities efforts, so we can make some headway.
Absolutely. I'll have Angie Parker reach out to Molly and get those conversations started.
It'll help us with contracting with the MCOs as well.
Yeah, thank you. We'd appreciate that.
Okay. Any more questions in regards to that? Okay. Next item, emergency credentialing.
This is Yvonne. I was asked to bring this up. So we know the recent disasters we've had in Eastern Kentucky, and it came to the attention when, you know, some of the clinics were trying to help mobilize some providers to get into some of the disaster areas to get patient care moving. And it raised the question of emergency kind of response to get providers linked. So if we, for the example, if we have a Medicaid provider that's with a clinic, and the other clinic, there's been a declaration of emergency by the governor or the president, and that clinic wants to help send some of their providers into the area, we need to be able to quickly link those providers to the clinic area that's going to be servicing that area. And, you know, our normal state to get a provider that's already in the system relinked under a different tax ID number can take multiple weeks. So we're asking for some type of consideration to have some time, when there's an emergency declared, that we can get these providers relinked to other groups. They're all safety net providers. They're already in your system, and get those set up quickly. You know, we need to be able to respond in a day or so, not weeks. So I just want to put that out there, how we might achieve that. If it's that we can quickly get them linked, and then we have a time period to get all the documentation sent in to make that final. Is it a period of time? So I just want to put that out there for some feedback and discussion.
So Yvonne, just to clarify, it's not an issue about in Medicaid enrollment getting the person linked, but rather probably through the MCOs. Is that where the issue lies?
We need to, so if you have a physician that's with Clinic A, and Clinic B has suffered a disaster, and Clinic A says, hey, Clinic B, we'll send our providers in to your area to help you because your provider, we've had providers that couldn't get to work, they lost their homes. There was all kinds of things that happened, but it came back to where they were going into that area. There was concerns that they couldn't get them quickly linked under Medicaid so that they could provide the services under the clinic that they were kind of, loaning the providers to. That's not the best word. So if a provider is already in the Medicaid system, they've been through their credentialing, everything's good, and they move, they change locations, they change employment. You go in and you use your MAP 347 and you relink them to the new groups that they're now employed under. That's just a process that takes time. We're just asking for consideration to be able to expedite that process.
Yep.
Anytime there is an emergency declaration.
Okay. Gotcha. So I'm surprised to hear it's taken weeks because generally those things can happen within a week. But certainly, I think the approach you could take is to we obviously expedite when we know that the situation warrants it. So I would go in and make the change in the system and then send an email to the provider enrollment box indicating an emergency and I need to expedite. And they should, and we'll make sure that provider enrollment's aware of, that we're sharing this guidance. But I think anytime they get something from a provider that says this needs to be expedited, we always try to take that into consideration and move those things through quickly. We do that a lot for emergency situations where the member is getting care. We'll enroll a provider very, very quickly, like within 24 hours. So certainly my advice is to make the change in the system and then send an email, to that provider enrollment box and just indicate the request for an expedite.
So,
go ahead.
So the normal process it usually does take weeks or whatever. So you're saying if we go ahead and initiate the process and then we send an email, that should expedite it. So that
they can go in and approve that. If everything's there, they can approve that very, very quickly.
Okay. I guess, so that really doesn't need to be a recommendation of the MAC. We already have something in place that.
We do. Mm-hmm.
Okay.
Yeah.
Okay. So hopefully we don't have to try that real soon.
I know. Yes.
But.
And so do you all have any languishing requests that need to be approved? And if so, then if you could email those to the email box, to the provider enrollment email box. And like I said, we'll make sure that those get followed up with.
Okay.
This is Chris. I just wanted to confirm. So the email that we should send a follow-up to, as far as we do the MAP 347 and we want to let them know the circumstances, it's going to the provider enrollment email.
That's right. Yeah.
And we can always copy you on it to make sure that it happens quicker.
You're welcome to.
Okay. And then at times, some of us didn't have internet.
Right. Yeah.
So it does make it, I guess, more crucial to expedite it once we actually get online.
Absolutely. And that's an excellent point, Barry. So I think that, again, you know, if you all are in a crisis or an emergency, I would like to hope that if you called our 877 number, which is for provider enrollment, and talk to somebody, that we get right on top of whatever it is that we need to do to help you all. We're here to support you. We want you all to not have to worry about these administrative burdens when you're trying to deliver care. So we want to help. So don't ever hesitate to, you know, again, email the box or call that number. If you're having trouble with it, escalate it to me. Happy to check and see what's going on. But you know, we're here to support you all.
Yvonne, how cumbersome of a process is it to link a provider? Say if Chris wanted one of her providers to come and work with us during the flood, or vice versa, we wanted to send somebody to work with Chris during the tornado. What is that process? How cumbersome is it to link one of her providers to our clinic?
Well, to start with your Medicaid, you're going to start with your MAP 347. And, you know, there is a documents that you need to send along with that, which is, you know, you're sending provider information, MPI numbers, tax ID numbers, malpractice coverage, all those documents go along with that. And if someone's in a state of emergency or their clinic has just been wiped out, you know, or their internet's out, will they be able to produce those documents quickly, fast enough to get them sent through? And
so Yvonne, let me just interrupt for a second to make sure I understand. If they're already a Kentucky Medicaid enrolled provider, we shouldn't need, all you're doing is linking. We shouldn't need all of that additional information.
But your 347 form requests all that.
Requests it, okay.
Yes.
So I guess, is there a way we could have a 347BE for emergencies that bypasses all of that information since you already have it?
I have to apologize. We don't have somebody from enrollment on, but we'll take that back.
Yeah. I guess that's what we're looking for, is maybe a quicker process.
My understanding, again, I'm not the enrollment expert, but my understanding, and this is helpful, Yvonne, is that when you're linking to another group of a current Medicaid enrolled provider, it's just submitting, you know, the information for the organization, for the provider that gets linked and for the organization it's linking to. I did not understand that all this additional information had to be provided at the time. So perhaps we can clarify that in guidance for the documents. I mean, for the partner portal, as you're walking through doing that for a currently enrolled provider, you know, we can take that back.
Okay. I think
it's still, everything else still applies. I mean, if it's an emergency situation or if you ever need an expedited, then to email the enrollment box or to call the 877 number and make that request that way.
Okay. But I like Barry's suggestion of maybe a 347E for an emergency, which, you know, all we can give you right now, because all our documents are not readily accessible because we're in a disaster, that we, you know, you have all that information on that provider, so we get them quickly enrolled. And then if we have to follow through, you know, in 30 days to get all the other supporting documents, that we can somehow make sure it's going to go through, and not that we send it in or we get it through and then say, well, you know, I need this document or I need that document. That's what we're trying to prevent. Or at least have a quick expedite and give us time to get the documents if we need that time.
Just get with provider enrollment and see if that's an option for us. And that's only for emergency purposes. That's not to get around the normal process.
Right.
Correct.
I see some questions on the chat. I'm sorry. Dr. Cantor, who should we send this info to? I guess that was in regards to the SUD services.
That's
Aaron
correct.
Bickers.
Thank you.
Dr. Throw, we have a maternal health side by side. Currently it's being updated, but when it's done, I can send it out. Does KPCA still credential our Medicaid and linkages through KOG? Molly, does KPCA still credential our Medicaid and linkages through KOG? Do we know that?
Hey, Barry, this is Noel. I can share with you that for members who have currently signed the delegated entity form with KPCA that are members of the association,
yeah,
we provide that enrollment assistance.
Okay.
But it's very specific to, you know, not every member of the KPCA wants us to be the delegated entity. So we only do that for those that have signed the delegated entity form over to us to provide that service for them.
Okay. Sounds good.
Barry, is that good?
Yeah, that sounds good.
Okay. And I will follow up with you all. I've got lots of thoughts and a long to-do list. I think we can clean some things up.
Okay. So stay on the agenda. It'll be old business, emergency credentialing, and Veronica, you'll have Angie to follow up with us on it.
That's correct.
Okay, thanks. Appreciate it.
Yeah, and Veronica, I'd be happy. This has we've got people on the federal level, state level. There's all sorts of complications, and we think we have some solutions to avoid some obstacles. So thank you for cooperating.
Of course.
I want to, if I can, for new business updates with the MCOs, just want to bring up one quick issue about about the monoclonal antibody. Maybe the MCOs can kind of help update us on it. Now that we're not eligible to get the monoclonal BEB treatment from the state and federal, we are now have to go through the insurance companies and Medicaid and MCOs to get it. Our billing people, and I'm sure Yvonne's having the same issues. We're finding that it's on the COVID fee schedule, but we're not able to bill through our MCOs for that service. And for those of us that's been providing the service, then that means that we have to kind of cease it because it's a very expensive treatment. It costs us around $2,100 to provide that treatment. So I'm just trying to get clarification if we're going to be able to continue to cover that service and be able to bill for it and get paid for it. And I know Veronica and I have been having some discussions about it. If we could get some clarification.
Yeah, I would like to make the statement that it is a covered service. So we'll then talk to the MCOs. You're welcome to, if you're prepared to. Obviously, it's new business, so you might not be prepared to, but right. It should be covered. So if the MCOs have any, I guess, update around that, that would be helpful.
Okay. And I know that we're going to provide some denials from the MCOs to the RAP box and Veronica, so she'll have that info. So I just, before we have updates from MCOs, I want to open that up. So instead of us going back through and asking that question later, they have the opportunity to answer it if they have an answer for it. So at this point in time, we'll take updates from the MCOs. So you want to start?
Hi, Barry. This is John from WellCare. Oh, I'm sorry. I talked over somebody. Go ahead. I apologize.
Oh, thank you. This is Dr. Cantor with United Healthcare. Good morning. I appreciate the opportunity. I put in the chat the codes that you're using for the monoclonal antibody. That would be helpful if someone could send that, so that way we can do the review of what's happening on our end. That would be great.
I actually have it. It's Q0222.
Okay, thanks.
That's the actual
But
medicine.
our updates, a couple things. In April of this year, the legislation passed extension of postpartum benefits. So after someone delivers, no matter what kind of delivery they have, their extension of Medicaid benefits are for 12 months. And I'm trying to get that word out everywhere possible. So making note of that to this audience is fabulous. The other update that I'd like to give is our Eastern Kentucky disaster response from United Healthcare. We did a PA suppression for all the providers in the impacted area, beginning in that date on July 29th until September 9th. We did a fair amount of pharmacy overrides. We spoke with providers in the region itself, and we were able to donate $208,000 to the area for community engagement, relief, and it also went to the Kentucky Rural Health Collaborative. So we did a fair amount of work for them, and our hearts go out to those in Eastern Kentucky. It's still quite an impact there. Those are our two updates. Thank you.
Cantor, we really appreciate it because we're putting good use to that donation to the Kentucky Health Collaborative.
Good.
We have recipients receiving their appliances today and tomorrow with part of that.
Oh, good. Good. We had our care management team reach out to those members in our complex case management, and that's been well received as well. So good. Thank you.
Okay, Johnny, welcome.
Hey, Barry. How are you today, sir?
All right. How about you, Johnny?
I'm doing fine. I will get back with you on confirmation on the monoclonal treatments. If it's okay, I'll give Sheila a call, and if she's got a couple of examples, I can take that back and get you some definitive confirmation on that.
Okay.
And tomorrow is my biweekly WellCare Informational WebEx that I've been hosting for a number of years. Last time I covered appointment agendas and using the portal on how to do that to make it more efficient. I'm going to do a part 2 tomorrow. So that's our biweekly WellCare Informational webinar that I host at 1 o'clock. So if anybody has that invite, if you need it, you can shoot me over an email, but going to be covering that. Had a great response last time. So that's my update. Thank you so much.
Hey, thanks, Johnny.
Hi, this is Pam Trigilio. I'm with the provider relations team for Humana Healthy Horizons in Kentucky. My update for today, just informational. We had some recent changes to my provider representatives. So if you would like to reference the most updated list to find out who your provider rep is, you can go on our website under the provider documents and resources page. And I also wanted to let you know to just be on the lookout for our new version of the New Horizon newsletter that will be coming out soon. That's going to have some really important topics for providers in that.
Okay.
This is Samantha Harrison, also with Humana Healthy Horizons. I did want to let you know that we are researching the code 20222 for any denials so that we can make sure we take action as necessary. Also, we have responded at Humana to assist in the Eastern Kentucky floods. High level, the Humana Foundation has donated $500,000 along with associates donating over $100,000. We've supplied PPE and medical supplies of about approximately $100,000 and 2 associate household item drives and office furniture donations at scale. So just an FYI, and wanted to let you know of those efforts provided by Humana, Healthy Horizons, and Humana. Thanks.
We really appreciate those efforts as well. Being from Eastern Kentucky and having a lot of patients and employees that's been impacted by the floods and the devastation. Thanks on their behalf.
Hey, Barry, this is Courtney Kelly at Passport Health Plan, if it's okay.
Yes, definitely.
Great. So again, we want to echo what all the other MCOs have said, and just our hearts go out to everyone impacted by the Eastern Kentucky floods. And, you know, we kind of as well did very similar activities and holding some PA requests and helping with pharmacy and medications and things, and also making some donations and making sure all of our folks in case management were definitely outreach to and providers as well. So just want to say, again, we're keeping on, and we know that the fight continues to kind of get back to stabilization and normalization over there. And so again, just a couple of updates though for our team. We did have recently, we have been partnering with a few new partners, and just wanted to make sure you guys were aware of that. We've sent a couple of e-news communications out, and we will be sending more, but we've got a few new partners we wanted to make sure you guys were aware of. Our New Century Health partner, effective October the 1st, we'll be partnering with them to help with our chemo-related drugs given for the cancer diagnosis for all provider types. I don't know how much these others will impact this group, but another partner of ours will be Periscope, effective October the 1st. They will be helping us conduct some comprehensive in-home member assessments for prior authorizations as it relates to new power wheelchairs and accessories. And then our new other partner, Progeny, as of August the 1st, we have been working with them to establish our NICU babies and kind of make sure those are managed. And then we also are sorry, I was taking a breath, but our MCG site auto auth for Medicaid advancement imaging requests. So effective September the 9th, we'll be introducing a new self-service method for our Medicaid line of business for advanced imaging and prior authorizations requests. And so all this information can be found through our e-news communications, but wanted to make sure you guys heard it from us as well. And then we also have a couple of new folks on our team. So if Yolanda Cowherd is on the phone, she is a new provider services representative. And then we also have Julia McCormick, who is our new director at provider services within Passport by Molina. So thank you guys for your time.
Thank you, Courtney. Appreciate it.
Hey, Barry, Brian Richardson with Anthem. Just wanted to jump in. Thank you for the opportunity. We have a few new links that we put out on our website, anthem.com. So just wanted to share those with the group. And they refer to facility vaccinations in the practice and the understanding of those vaccinations. And we also have one for early periodic screening, diagnosis, and treatment. There's a COVID update one. And we also have one for HPV, the Provider Incentive Program, and that's for members age 13 and up. So as I stated, there's 4 new links, and they've been added to our website at anthem.com. Just wanted to share that with the group. Ken also has something that he wanted to share also. He's going to chime in.
Okay.
Hey, good morning, everyone. Ken Groves. I guess you guys hadn't heard from me for a while. I want to give an update on RAP. So we discovered this issue back in April. So this one, RAP, has not been issued on some encounters with other primary insurance. So basically the issue is when other insurance pays more than the allowable, Anthem reports our paid amount is 0. Well, we should be reporting our allowed amount, but due to a configuration error, we've only been reporting the allowed amount as 0. Unfortunately, this has caused encounters to be sent as denied instead of 0 paid, which has resulted in encounters not being paid. So there's going to be a system fix that's scheduled for 9/16. However, in the interim, we've been reprocessing claims, pulling reports, and we'll continue to do so until that system fix has been in place. And just FYI, this did not affect all COB claims, only just those that were FQHC, RHC, and other insurance. Thanks.
Okay, thank you.
Can I ask a question? Ken, this is Yvonne. So you will go back and you will locate all these claims and you will reprocess them, or do the clinics need to notify you of it?
No, they don't need to do that at all. So since we discovered it, we've been pulling reports to reprocess, so they should not take any action. So what'll happen is they may see the denial, but we'll pull the reports after they did, because they have to go through the system. They deny, we'll pull the reports. Then after the 16th, then therefore the issue would be totally resolved. But definitely tell them not to bother with any action. We will reprocess those claims. So they should see an adjustment on anything that's denied for those claim types.
Okay. Thank you for sharing that.
Indeed.
Ken, this is Chris. I again just wanted a little clarification. So we're talking about members who have a primary insurance and then their secondary insurance is Anthem. So the primary insurance pays more than an allowable, and then when the claim gets sent to the secondary insurance, which was Anthem, instead of 0 paying and getting information that indicated that the clinics were getting a denial.
That's exactly right. They were getting denial as opposed to showing a 0 pay.
Okay.
Hey, this is Jeremy Randall with Anthem. Yeah, and this was a lot more about how encounters were being submitted over to the state to trigger that RAP payment. So everything, probably looked okay from the provider's perspective on the claims that we were actually adjudicating, but then it was how we were submitting the encounter and therefore how, the impact it was having on the RAP payment. So, we've been doing so much, in the last 12 months, based on the RAP data that the state's been giving us. And so this is just one of those opportunities we identified, within, our RAP payment research to try to really, optimize and make sure that, every single one of those paid encounters is having a RAP payment, being issued to FQHCs on the back end.
I have one more question, Ms. Yvonne. How far back will you go in your data?
Well, that's really a case by case kind of basis. So, happy to, discuss, that in more detail with the, individual providers, if they'd like to reach out to their provider rep, if they haven't already.
Okay. Jeremy, you're not notifying individual clinics that we found this issue with their claims, or it was across the board to all Qs and RHCs in related to what was sent over to DMS for the RAP.
Can you ask that one more time, please?
I'm not sure if I can actually.
She's asking, have you sent this in? Is this a wide scope problem, or is this unique to some clinics and not others?
Yeah. So no, it is. It does potentially impact all. So,
okay.
Our philosophy is, we try to find issues, and maybe that issue came up because of an appeal or a state complaint or something like that. That's how it hits our radar. But then once we identify that there's an issue, we'll address the root cause across the board and then adjust claims proactively across the board. So, yeah, to answer your question, it's potentially everybody.
So I think the question was, Jeremy, are you all notifying in writing the providers?
So I will have to lean on the provider team for that. We'll get back to you on that. I think that, the notification probably has not been across the board consistent to everybody because, we've let kind of the RAP payments themselves be the notification, as those are issued, by DMS as these things are getting cleaned up. So it's a good question. And let me just circle back with the teams that are handling that. And we'll get back to you.
I think I'll speak on behalf of us. It would be nice when you find things like that to put that in a blast to all of the providers, so they can be on the lookout on their side.
Yeah.
And that should go for all MCO. When you find a wide scope problem like that, that should go to everybody.
I will say that I believe this has been included in like our weekly updates to DMS on some of the RAP payment efforts.
So I'm just trying to, I'm sorry, Jeremy, the impact to the clinics could be they're not getting the RAP payment that they were entitled to because the claim went through as denied, and DMS sees, well, then it's not eligible for the RAP. So we have clinics who are being denied the RAP payment that they should have been received. Is that correct?
That is a fair summary. Yes.
So then how will the clinics know? I mean, like right now, and Vaughn, you know, jump in here if you need to. If we get a denial if we don't get a RAP payment, then we have billing staff members who are chasing, why didn't we didn't get the RAP payment? And then, you know, in looking at the information that's available, it says denied, and they're confused by that. So then they're chasing this down and more work is going into this. So if the clinics are notified, we've got a problem with your, you know, with the RAPs, you probably are due RAP payments that because of this issue, you all don't need to do anything. And when Anthem works this process themselves, then the RAPs will kick through sometime, you know, 30 days, 60 days or whatever, but we're still keeping this claim open. Yvonne, would your clinic not kind of put the same effort into this?
Yes, very much. That's the reason I was asking, you know, how far back are we going? But also, I think the notification out to the clinics is very important because they're working these things and maybe they're doing it on that individual basis. And it's very labor intensive. I think we all understand that. Mm-hmm. But once you know, any MCO knows that you have found a system widespread issue that you're resolving or working on, notification would just be so helpful to everybody, because then you can then flag that for follow-up, but you can stop all the labor intense trying to make calls and do whatever you're doing to find the answers to that.
I mean, I would even go as far as to say, you know, if you know the tax ID number that is involved on that claim, you know, that this tax ID number has 20 claims where that was a problem, or 120 claims, I think the provider needs some sort of notification that says, you know, this is what's happened and why, and that the MCO was working on it and correcting this issue. And so, you know, our staff is, you know, aren't spending a lot of time and effort trying to chase this down. So is that a possibility?
Yeah, that's absolutely a fair point. And, you know, it's well taken. So we will find a way to make this happen, you know, so that we can get that proactive messaging. It's just a matter of, you know, timing and, you know, distribution, et cetera. You know, we just got to work out those operational pieces. But yeah, I get your perspective.
And I think you were brave to bring this up. And it's nice to know that doing some self-reporting, but I think from DMS standpoint, it ought to be consistent. When we have a system-wide problem with the MCOs or DMS, we ought to be made aware of that, you know, as fast as possible, so we don't expend our resources on trying to fix a problem that somebody else created, and we're trying to figure it out when you already know it, I guess. Was that accurate, Veronica?
Yes.
I don't know if we need to, make any recommendation or anything of that nature other than just be aware of it and, let's adhere to it.
Well, Barry, again, on the other side is we certainly get notification when there's a, we're going to take your money back, this kind of thing. So, it should work both ways.
Agree. And as far as timeliness, I mean, if there's a problem that stemmed from the MCO, they should be waiving timeliness issues if they have to fix it. So I don't know if we need to, in the future, that's one of those standardization items that we need to look at with contracting. Because I know that we've had that happen in the past as well. So Molly and Veronica, I hope you guys are keeping notes of some of these items when we start talking about contracting and stuff to keep in mind.
Veronica, do you think we should bring this back up in our RAP work group? Maybe that's another place we can try to get a little.
Yeah, I think that would be, I think that would be appropriate. Yep.
Okay. Any more updates from the MCOs?
This is Dan Brunner. Can I update you on our disaster relief efforts as well? Yeah. We donated $50,000 to Foundation for Appalachian Kentucky, and also $50,000 to the governor's Kentucky Relief Fund. We reached out to our members affected in the area, making sure they have access to medication, preventative care, whatnot. Delivered Narcan fentanyl testing strips to local providers there. We actually drove out a van of 180 box fans to help with drying. Actually, our local team did that. And through our Anthem Foundation, we were able to match employees' donations to a $1 million grant to the American Red Cross and $250,000 grant to Direct Relief as well. So we also are keeping them in our thoughts as well as they suffer through this long term.
Okay, thank you, Dr. Brown.
Thank you.
I didn't hear anybody really addressing the monoclonal issue, so Veronica, we'll send you these. The reason I'm trying to stay on this is it's very crucial because the last dose of a bed came out through the state last week. So it's going to cause a lapse in getting this monoclonal treatment out to some of our patients that really need it. So please forgive me for my persistence, but I'm going to be persistent. We'll get you the denials, Veronica, on the RAP box. Is that all the updates from the MCOs?
I think we heard from Aetna.
I'm sorry?
We heard from Aetna.
Sorry, I was trying to come up. This is Crystal with Aetna Better Health of Kentucky. Our teams have actually been out in Eastern Kentucky. We had our community outreach teams and CHWs that were sent out into the areas that were impacted. We worked with providers and members who were impacted, just trying to make sure that they have access to care, any kind of supplies that is needed. We've made several trips into the area, just taking those donations, making sure that we can do what we can from our end. We've also partnered with several providers to see how that we can assist them going forward and to try to help you get them up and running so we can make sure that, our members that have been impacted is actually able to see those providers. We have suspended the PA requirements for those counties, and we will continue to work with the members as well as providers in that area to make sure, if there's any kind of issues that come up surrounding the PA requirements, anything like that, they can outreach us. We will take a look at those cases. Let's think. Just trying to make sure I cover everything. We do have several provider trainings available that we do monthly. and those can actually be found on our website. If anyone would like a list of those, we can actually send those out. And in regards to the code 20222, we will have to take a look at our system to research that code to determine if we have any denials, and we can provide that update next month.
Okay, thank you for the update. Any other updates from the MCOs? Okay, let's go on to the next agenda item for general discussion. Do we have anything for general discussion? Okay, seeing no general discussion, do we have any recommendations for the MAC from our TAC? I don't think anything come out of this meeting. I don't think we have any follow-up items, recommendations for the MAC, do we?
No.
I don't think that. Yeah. Okay. MAC meeting representation.
When is that meeting, Barry?
Veronica?
It's September 22nd. Oh, sorry, Veronica.
Yeah, I'm sorry. Yes, September 22nd, 10 o'clock.
And that's on the agenda more so that when the MAC starts to go through to get updates from TACs, if there's not going to be a representative, I can let them know that there's not going to be someone there.
Yeah. I am actually on the MAC. So if something happens that somebody from the TAC does not report on behalf of the primary care TAC, I will make that report just in case. I let that happen one time. I won't let that happen again. So.
Thanks, Barry.
Yeah.
Thank you, Barry. Yeah.
Thanks, Barry.
Okay. Next meeting for our TAC is November 3rd at 10 a.m. Is everybody okay with that?
Yes, sir.
Yes.
Okay. Just in time for the leaves to start changing. So all the MCOs, we appreciate all your efforts helping us out with the flood relief, with everything that you guys do. We continue to want to have a great working relationship with you all and with DMS, and we appreciate all of your efforts, especially with DMS. We appreciate you, Veronica, and your staff. And we will see you in a couple months.
This is Chris. I'll make a motion to adjourn.
Okay, so I got a second. All in favor, say aye.
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 So moved. Y'all have a good evening.
Thank you, Barry.
Thank you, Barry.
Thank you, everyone. Have a great day.
Bye.